There is a weak relationship between ischemic test results, and outcomes for that matter, and the angiographic image. Think of it as a visual functional mismatch or an anatomic physiologic mismatch. Whatever you call this difference between what you see and what you get, well, it confounds the clinician and can lead to inappropriate treatment. So let's use some fractional flow reserve that can overcome this visual functional mismatch. And that's the topic of a paper in the November 29th issue of JACC. It is the lead-off paper. It is a prospective natural history study of coronary atherosclerosis using fractional flow reserve. And I'm with the first author, Dr. Emanuele Barbato, who is an MD, PhD, and an associate director at the Cardiovascular Center, Aalst OLV Clinic in Belgium, and an associate professor now of cardiology at the University of Naples in Italy. This is a very creative paper, first off, so congratulations. Let's start with its origins. How did this whole idea come about in order to do this particular study?
Well, it came about at the very time the FAME2 trial was designed. As you know, the FAME2 trial has compared two treatment strategies of patients with stable coronary artery disease. On one side, conservative medical treatment, optimal medical treatment with the current standard we know nowadays, as compared with percutaneous coronary revascularization combined with optimal medical therapy. So the results of the FAME2 trial showed that the primary endpoint was superior in the FFR guided arm, PCI guided by FFR, as compared with conservative medical treatment. We have to say that all these patients presented at least one coronary stenosis with an abnormal fractional flow reserve. It means that they had underlying myocardial ischemia. So we ended up with a whole group of patients with coronary stenosis that have been invasively characterized by a functional point of view, by FFR, that were just followed up to 3 years, and nowadays we are accumulating data for 3 and 4 years follow-up, where we just did not intervene, if not with optimal medical therapy. So at the end, we have the whole group of patients randomized to medical therapy, having an abnormal FFR, together with a registry group of patients where fractional flow reserve was measured in all the coronary stenosis visible at the angiography, but their FFR was not abnormal, was not altered. And these patients were kept in the study, but into a registry. And the idea for this study stemmed from the fact that we wanted to pull together, do an analysis of all the patients where coronary stenosis were all measured with FFR and just followed up. That's why natural history of coronary artery disease by FFR.
So what did you find with these rather interesting patients where they obviously did not undergo PCI?
Right. What actually we found is that these patients presented events up to 2 years follow-up. That is what we report in this specific paper. And these events were directly correlated with the degree of abnormality, of alterations, if I may say so, of fractional flow reserve. In other words, the lower the FFR values in this stenosis, the higher the chance that these patients would have event related specifically to the vessel we measured.
So in terms of, for example, the relationship you found was not linear.
Correct.
With the largest increase in MACE was occurring between an FFR value of 0.60 and 0.80?
Correct, yeah.
Now, that certainly supports the value of looking for an FFR that's less than or equal to the 0.80, right?
That is very true. What you say, on one side, these data confirm the, let's say, the reliability, the usefulness of having an on-off threshold value. If you are above, don't touch the vessel with a stent. If you are below, you better treat the vessel with a stent. That is what has come about from this paper. But on the other side, it also emphasizes what has coming out recently, that there is a continuum risk, even with stenosis, presenting fractional flow reserve above 0.80. It's all about how do we want to tackle these lesions. The message of this paper is the following one: as long as you have an FFR below 0.80, you better put the stent on top of the medical therapy. Right. If you have an FFR above 0.80, it's not that these stenoses are not at risk of events. They can still have events, but you better leave them alone. You don't touch them with a stent, and you treat them with medical therapy.
So the 0.80, that's the appropriate treatment threshold, you would say at this point, for undergoing PCI, if the patient wants it.
That's right. That's right.
Now, as one might expect, angiographic diameter stenosis, that was not associated significantly with MACE And that's after you correct for all the potential confounders, right?
That is true, and actually this confirms what we have seen and witnessed over the last 20 years. Each time we tried to adopt imaging techniques alone to guide PCI or to guide our invasive treatment, we never ended up with a clear-cut significance in clinical outcome. It is true that with novel imaging technique, if PCI is guided by imaging, we can end up in better results. But here we speak about indicating treatment or deferring treatment. In this sense, once again, this analysis demonstrates that the angiographic tool alone, the coronary angiography alone, is not sufficient to characterize, to stratify those lesions and those patients at higher risk of events at the follow-up.
One of the issues now is where should FFR be used? How should it be used? What does your paper tell us about answering that question?
Well, the paper doesn't say that we should use FFR in all the coronary stenosis we see. Of course, if the patient has behind him a non-invasive diagnostic workup that already demonstrates the presence of ischemic heart disease, and it comes in the cath lab with a single vessel stenosis, then there's not much to do there. We just need to go on and treat these kind of patients. The role for fractional flow reserve is really in equivocal situations, and there are many of those cases in our daily clinical practice. I think to the intermediate stenosis, multivessel disease, all the kind of situations where we are not certain about what should be the right treatment strategies in this case. FFR has demonstrated that it can pinpoint the right lesions to treat, the very stenosis that is responsible for myocardial ischemia and eventually for the symptoms of the patients. That is where FFR should be used.
So you're continuing to follow these patients?
Right. Actually, this is a sub-analysis of the FAME2 trial, right. And the main FAME2 trial has the objective to follow these patients up at least for 5 years. So within the context of the big FAME2 trial, we will be also following up this subgroup of patients.
And this was a pre-specified analysis. I mean, you really were thinking ahead in terms of how to do this and how to do the study.
You are totally right in that. We really thought carefully to perform this study simply because this is a patient population that will never happen to be available any longer to interventional cardiologists. How many physicians will you find in the future that will measure an abnormal fractional flow reserve in a proximal LAD of 0.6, for example, right. And they would just stay away from it and leave them alone and treat them with optimal medical therapy? I'm not sure you will find many of those colleagues out there.
I think you're right. So what's the take-home message? What do you want people to get out of this particular paper?
So the take-home message is that we have actually two important take to rely on. First one, you can use a very practical threshold value to decide whether to treat with percutaneous coronary intervention and medical therapy or to defer this patient to medical therapy alone. But we need to be aware that fractional flow reserve monitors a biological phenomenon. And a fractional flow reserve above 0.8, it doesn't mean that we should leave these patients alone and don't follow them up accurately. These patients are still at higher risk of events, and they should be intensively be followed up, treated with medical therapy, because if we don't do well our job, down the road they might still have events, though at a lower rate as compared to the patients with FFR below 0.80.
Well, Dr. Barbato's paper is the lead-off article in the November 29th issue of the Journal of the American College of Cardiology. Please check that one out online. For CardioSource World News and CardioSource World News Interventions, I'm Executive Editor Rick McGuire.